Namaste friend, welcome back to ICU with Dr. Bhautik. In our previous lecture, we discussed low tidal volume ventilation, PEEP titration, driving pressure and prone position. Today, we will discuss another important ARDS therapy, neuromuscular blockage. Many ICU doctors are uncomfortable using the paralytic because of the worry about the weakness and complications. But when used correctly, the neuromuscular blockage can improve the oxygenation, improve ventilation synchrony, and reduce lung injury. The key question is not can we use paralytic. The real question is when should we use them and when should we stop them. Let's begin. Why do ARDS patients fight the ventilation? ARDS patients have severe hypoxemia, high respiratory drive, and increased work of breathing. The patient want to breathe faster and harder. The ventilator is delivering the control breath. This mismatch causes the patient ventilation desynchrony. Example: double triggering, breath staking, and reverse triggering and flow starvation. Okay. This increase the transpulmonary pressure, lung stress, and driving pressure, ultimately causing the VILI. How does the neuromuscular blockage agent work? ठीक है कैसे वो हेल्प कैसे करता है ठीक है Neuromuscular blocking agent is temporarily stop the skeleton muscle activity, and this eliminates the spontaneous respiratory efforts. Benefits like protect the ventilator synchrony, reduce oxygen consumption, reduce work of breathing, and more stable transpulmonary pressure. Less breath taking, less volume trauma, and less atelectic trauma. ठीक है think of neuromuscular blocking agent as giving the injured lung complete the rest. Evidence behind the neuromuscular blocking agent. The landmark is ACURIS trial. Early severe ARDS patient received the cisatracurium infusion 48 hours later. Results are better oxygenation, better ventilator synchrony, reduced lung injury, lower mortality signals. Later study shows the mixed mortality benefits. Currently, understanding our neuromuscular blocking agent is not for every ARDS patient, but remain useful in the selected severe cases. When should we use? Strong indications are like PO to FiO2 ratio 150, less than 150. Despite the adequate sedation, appropriate PEEP and lung protective ventilation. Other indications are like severe ventilator desynchrony, despite of sedation, refractory hypoxemia when the oxygenation remains poor, uncontrolled driving pressure despite of the optimization during the prone ventilation to facilitate the safe proning, and higher respiratory drive causing the self-inflicted lung injury, also called PCL. Okay. Which drugs should be used? Okay. The preferred drug are cesatracurium. Why? Organ independent metabolism, no renal adjustment, no hepatic adjustment, predictable duration. Alternative atracurium and vacurium. Avoid prolonged use of the succinylcholine because it is not suitable for the continuous ICU paralysis. Dosing and duration. The loading dose is 0.15 mg per kg followed by infusion 2 to 4 microgram per kg per minute. Always titrated clinically. Important rule: do not continuously paralyze unnecessary. Most studies used 48 hourly. Longer duration increase the complication like monitoring while the neuromuscular blocking agent. Paralysis without the monitoring is dangerous. Always monitor sedation target. Deep sedation RAS score 4 to 5. And remember, the paralysis patient may still be conscious. Therefore, sedation come first and paralysis come second. Analgesia. Adequate pain control is essential. Usually opioid infusion, fentanyl or remifentanil. Top monitoring, train of 4. Target 1 to 2 switch out of 4. This indicate the adequate paralysis. Goal while using the neuromuscular blocking agent is better oxygenation, better synchrony, low driving pressure, plateau pressure less than 30, lung protective ventilation, reduce VLE. This is the goal are to achieve and start planning for the stop neuromuscular blocking agent. Risk and complications. Okay. Risk are like ICU acquired weakness, most probably complication, critical ill myopathy, especially in the prolonged paralysis, corneal injury because the patient cannot blink, eye care is essential, pressure injury, need frequent assessments. Awareness during the paralysis, one of the most important complications. Always ensure the adequate sedation, analgesia, never paralyze an awake patient. How to stop neuromuscular blocking agent. Okay. Okay. Then do not continue automatically. Reassess daily. Oxygenation is asked. There is a oxygenation is improved or not. Synchron is improved. Driving pressure is acceptable. If yes, then stop the infusion. Continue sedation. Monitor the top and begin the ventilatory winning strategy. Practical ICU approach. Step 1. Diagnose severe ARDS. Step by step approach देखे तो diagnose severe ARDS PO2 FiO2 less than 150. Okay, within 48 hours. Step 2. Optimize the ventilation. Low tidal volume PEEP or driving pressure reduction. Step 3. Provide adequate sedation. Okay. Then step 4. Start seat tracheum. If severe desynchrony, then start seat tracheum. Step 5 is to top ABG, driving pressure, blood and hemodynamic monitoring. Step 6. Continue maximum for the 48 hours if possible. Step 7. When the neuromuscular blocking agent early as stop early as possible. Planning for extubation. Okay, so take home message from this is 7 points. Neuromuscular blocking agent is not routine therapy. Use it for the severe ARDS patient. Second, always combine with the sedation. CSAT tracheotomy is preferred. Monitoring with TOF. Use of the shortest duration of possible. Stop as soon as oxygenation and synchron is improved. Neuromuscular blocking agent is temporary bridge, not a destination. The goal is not paralysis. Goal is lung protection. Protect the lung, improve synchrony, reduce injury, and save the lives. Thank you. I am Dr. Bhautik. Next lecture, we will discuss the patient ventilation asynchrony, recognition, waveform, and management. Thank you. Thank you so much.